Good evening, everyone. I'm so happy to be with you tonight. My name is Leanna Levine-Reisner. I'm the Network Director of Plant Powered Metro New York. And we are in for a treat tonight to talk about a topic that I think is really addressing some very pervasive issues, some that we don't like to talk about with each other, even though they feature front and center as we live our lives. But Dr. Craig Zalvin is joining us to talk about pharma, not pharma, PH versus F, which makes a big difference. And we'll be discussing how diet can both prevent and treat acid reflux disease. I think to put this in perspective to anybody who's new, Plant Powered Metro New York is here to empower people to find better health and overcome chronic disease through nutrition, and specifically through whole food, plant-based nutrition, which we'll speak about further as we go along. And we have a number of wonderful doctors from the local community who are very well versed in these subjects, including Dr. Craig Zalvin, who's a member of our medical advisory board, as well as the medical director at the Institute for Voice and Swallowing Disorders and the chief of otolaryngology at Phelps Hospital, which is a Northwell Health Hospital in Sleepy Hollow up in Westchester. And he's a professor of otolaryngology at the Zucker School of Medicine at Hofstra Northwell, as well as a partner at ENT and Allergy Associates LLP in New York. He has a special focus on treating reflux disease with a mostly plant-based Mediterranean-style diet with publications in JAMA and Laryngoscope, highlighting the improvements and results over medications with the additional health benefits of preventing and reversing many chronic diseases, which we'll speak a bit about tonight as well. And his book, Laryngopharyngeal and Gastroesophageal Reflux, a comprehensive guide to diagnosis, treatment, and diet-based approaches, is the first to combine both fields and a diet-based approach to reflux treatment, which is tremendously exciting. And it's a technical book, right, Dr. Zalvin? Is it for the public or is it for your colleagues?
Yeah. It's sort of a bit of a mix. So,
Okay.
it certainly can be used for the technical aspect of things, but definitely everyone can read it and there's a lot of information in it.
Fantastic. So what I'll do then is put in the chat box here the title of your book in case anybody's interested in going much deeper. And I'm also really curious if folks would introduce yourself in the chat box, where you're tuning in from this evening, and also what brings you here. What are you most interested in learning, if not to help yourself, then perhaps to help others in dealing with reflux disease? Please go ahead and let us know a little bit about you. And I'll keep everybody on mute for now, just so we don't have noise, but we'll have plenty of time for Q&A when Dr. Zalvin is finished. So Dr. Zalvin, would you like to get started?
That sounds like a good plan.
Fantastic.
All right. So thank you very much, Leanna, for the introduction and the invite. It really is an honor to speak to everybody about a subject that I think is both very fascinating and certainly a favorite of mine. Also, it's really a pleasure to be part of PPMNY because I think that, we're learning a lot right now in our society. There's been clearly a lot of changes, some not so good, many very good. And certainly we're realizing that diet needs to play a far better role in our health, and not just reflux, but all of our health. And, part of my goal in doing these types of talks is to help educate both other educators, physicians, and people about the benefits. And in particular, my interest is with reflux disease. I am a ENT or otolaryngologist, but I'm a laryngologist specializing mostly in things of the throat, of which reflux is a big one. So here's a brief overview of my plan, which isn't working. Okay.
If it's not, oh, there we go.
There we go. So essentially, this is a bit about my journey into plant-based medicine. And I'll give a very brief overview right now, and then through my talk, you'll see where I've sort of focused myself on. I am going to talk about both LPR, which is laryngopharyngeal reflux. We'll talk about that, versus GERD, which pretty much everyone here knows about, or gastroesophageal reflux. And we'll review some of the current popular treatments. We'll go over a plant-based Mediterranean-style diet, and we'll look at not only how it can help with reflux, but clearly all medical illnesses can respond to some degree, And I'll go over some of the really compelling data that's out there. And finally, we're going to apply that to reflux disease. So, I myself, I was a, eat anything on the table type person up until about probably 8 years ago now, and started to realize that, what, something's not right with, diet. And I just didn't know what that was. I was also treating patients back then for chronic hoarseness and throat issues and reflux disease. And this disease, LPR, laryngopharyngeal reflux, was fairly new in, our medical literature. And I found that, I was getting okay results. I was giving them PPIs, Nexium, Protonix, Prevacid, all those different proton pump inhibitors. And, some were getting better, some were not. But I realized, they weren't getting that much results that I'd like to see. And certainly giving one medicine wasn't enough. So you had to give 2 and then 3. And I'm sure many of you have been through that story. Well, I got a little frustrated, looked to the disease literature of chronic disease, in particular with a diet focus, and realized that diet's really a major factor in the onset and propagation of many of our chronic diseases. So not surprising, reflux is a chronic disease. It helps with that too. And so I myself became 100% vegan for a couple of years and have since transitioned. I'm 98.6% vegan. I do cheat on occasion, and I think that's okay, even medically speaking. So with that, I'm going to get started and kind of go through all these different steps of where I've come and how I've really helped my patient population really cure their reflux disease, and without the use of the proton pump inhibitors. Oops. So GERD, gastroesophageal reflux disease. Well, everybody knows what this is. It affects millions at the cost of billions. We spend $70–80 billion a year on these diseases. The typical symptoms: heartburn, indigestion, fullness, feeling early satiety or fullness, stomach discomfort, pain, burning, and regurgitation. Those are symptoms that I'm sure everybody here has had at least a couple times in their lives, if not more, and probably many of you many more because you're here. So we know that there's millions of Americans that have this disease. And I say Americans because it really is a disease of Western society. And most of them have tried over-the-counter medications, prescription medications, and some get better, some don't. A lot of people do have improvements, but the problem is they're on these medicines forever. And, it's rare that someone starts these drugs, which, by the way, are only supposed to be taken for no more than 12 weeks. Yet they're on them for literally at this point, decades. And, you go to the doctor, they spend maybe 2.6 minutes talking about different dietary restrictions and whatnot. You're told to stay away from coffee, tea, chocolate, soda, greasy food, fried food, fatty food, spicy food, alcohol. Yes, I've said that a few times. And the meds do help. They decrease symptoms because, contrary to what you think, these medicines do not treat reflux. They treat acid. They suppress or lower acid. You can still reflux, and even a little acid, certainly in the throat area, is enough to cause symptoms. And again, most patients fail to change their diets, and they stay on these meds in many cases forever. So we're going to contrast that to LPR, which is laryngopharyngeal reflux. And essentially, this is when there's reflux that comes all the way up into the throat area and causes a variety of different symptoms. There are many names for this disorder because it's sort of not as well known as GERD is known. And it's been termed extraesophageal reflux, silent reflux. And that's because a lot of these patients don't have heartburn, indigestion, or typical GERD symptoms. The symptoms that they do have are, and listen to these symptoms, because I'm sure all of you have had some of these symptoms at some point. Chronic throat clearing. I mean, how many classrooms have you been in? And there's 5 people that do this all day long. Feeling of a lump or something stuck in the throat. Chronic coughing, especially at night while sleeping, or they may even awaken sleeping, where some people wake up gasping for air. Sour taste or burning in the throat. Swallowing issues. And some people do have some voice change, though I'll tell you that reflux doesn't cause voice disorders. I hear this all the time. it can exacerbate a problem, but there's always another reason. And so a lot of times people will go to the ENT, they'll stick a scope in the nose, and they'll say, oh my God, it's the worst reflux I've ever seen. It's so red. I don't really believe that. That doesn't cause hoarseness. It can exacerbate when it's really severe. In most cases, it's not that severe. And these are some of the other symptoms that people with LPR can manifest with. And as you can see, there really is a lot of overlap with other disease processes, such as asthma, sinusitis, and actually reflux can worsen these diseases. So somebody with an underlying pulmonary issue like asthma, with chronic acid exposure, it can make it significantly worse with more frequent episodes, more severe episodes. Recurrent sinus disease. We know that many patients with chronic sinus disease, the majority of them have chronic acid reflux that exacerbates the inflammation of the sinuses. Same with ear infections. Cough is a very interesting subject, and that's one of my favorite that I could probably spend a couple of days talking about. But reflux can be a cause of cough, but also a trigger of coughing. And it also can contribute to narrowing of the windpipe and, yes, cancer. We know that chronic GERD is the major risk factor for esophageal cancer, which frankly has increased multiple fold, 6 times to 100 times in some cases over the last few decades, and also cancer in the throat. So because there's so many of these amorphic symptoms and overlap with other diseases, it does lead to a misdiagnosis most of the time. And most of people who have all these symptoms are diagnosed with allergy, sinus infection, postnasal drip. Well, newsflash, everyone in the world has postnasal drip. We all drip 1 to 2 liters every day. So that's like a Coke bottle full of snot. The problem is some people make too much mucus because there's an illness, or they feel the dripping coming down. And reflux can help sensitize the back of the throat so people feel that dripping. And again, other diseases such as viral infections, asthma, and neurogenic. And I mentioned neurogenic because neurogenic means nerve-based. And we are now finding out that, guess what? Viruses cause nerve damage. Everybody's heard of COVID, loss of smell. Well, that's a direct effect from the virus affecting that nerve. Well, we've known forever that viruses can cause loss of hearing. You wake up and you can't hear. The face can be paralyzed. People can have vocal cords that get paralyzed also. In addition, it can cause sensory changes. So a lot of reason why people with chronic reflux don't get better is because the nerves are abnormal and they're just more sensitive. So this much acid in those cases feels like this much. And therefore, even a little acid exposure causes ongoing symptoms. And that's what we call, or I call, a post-viral refluxopathy. And so this is all technical, but we do know that when viruses affect the throat, there's increased numbers of receptors that can bind to things like acid, and mucus can stimulate them, and even talking or laughing can stimulate them. So if you have increased acid receptors, even a little acid can stimulate a response. And that's why a lot of people don't get better, is because they have ongoing mild acid exposure in the setting of hypersensitivity. Now, we have a lot of tools to try to diagnose these problems, and you don't need all of them. In fact, I'll argue you probably don't need any of them. Most of what we diagnose is based on a history and a physical exam. But these are tests that we do employ when there's particular difficulty in achieving a diagnosis, or somebody's not responding the way I would think they would respond. This is a picture of the larynx, and this is what we look at. You can see that these right here, these are the vocal folds. There's some swelling there, some swelling in the back. These are the arytenoids, and this is the epiglottis. And back here is where the swallow tube begins. And this is the tongue. Yes, I know, it's beautiful. I can see everybody felling about this. So my approach to diagnosis, as I said, is really, it's the history and the physical. That's going to give me the diagnosis 95% of the time. And what I do is treat. And in my case, I use diet. I mean, diet is now my workhorse 95% of the time. And then we go to medications, and I'll go through that as we move forward. I do testing for people who don't respond, And then I have to question the diagnosis. Am I wrong about my diagnosis, or are there other factors like the nerve factor I talked about? I do acid testing, and in particular, I test acid in the throat. We can measure pepsin, which is a digestive enzyme that's only created in the stomach. So if you find it up in the throat, that's a problem. And then I do all these other tests when it's indicated. One test I do a lot of is what's called transnasal esophagoscopy, or TNE. Now, people, especially over age 45, who have recurrent heartburn and GERD, all get upper endoscopies, or they should, because we want to make sure there isn't cancer. The problem with reflux when it affects the throat, the silent type, there are many people that come in with just a cough, just throat clearing, and they don't have heartburn, so they don't get the scopes. So I do esophagoscopies on my own because you don't want to miss something. I'll show you in a sec. This is an example of a tracing of acid. All these spikes are acid levels, and all at night is just constant acid exposure. And this can be measured. It's a tiny catheter, goes in the nose. You wear it overnight. I've done it a dozen times. Mild discomfort, if any, and really gives a strong exposure of what's going on from an acid profile. This right here is somebody's esophagus, a chronic cough patient, where I do an esophagoscopy. So you come to my office, put a little numbing medicine, I take a camera, I go in the nose, all the way down to the stomach. Done that to myself a dozen times as well. Don't ask. And this is what I found in some guy who had a chronic cough and some throat clearing. This is a large cancer of the lower esophagus that was missed clearly, but would have been missed a lot longer because didn't have the typical heartburn. And again, I don't do these things on everyone. This is for, in particular, when patients are failing to respond or fit a profile that they should have this. So to switch gears a little bit, I want to talk about some lifestyle diet advice that everybody gets and treatment for reflux, and go through basically the diet and behavioral modifications, because I do think they're important, the medical therapies that exist. And I'm not going to talk about surgical therapy today, namely because I think most people don't need surgical therapy for this, because this is something that we can treat with diet. But when they do, it's a different topic for another time. So behavioral, I really believe, is the most important. And obviously, if we could get people to change their diets, I always say, if we made people 95% vegan today, we'd probably close 80% of the hospitals within 10 years. And that's because we know a lot of our chronic diseases are based on our diet. Well, it's the same with reflux. And, we see a lot of studies that have been done looking at GERD and multiple factors and triggers. None of these studies have been replicated in the LPR literature, which, again, we're just sort of making that jump that if it happens with GERD, it'll happen with LPR, which really is not true. These are really two separate types of diseases. And although I don't have time to go into it, you can think of the esophagus as right down low next to the stomach. It is well protected against acid. We evolved that way to have a suit of armor on our esophagus. The throat itself, the larynx, and the throat, the pharynx, there's really minimal protection. So even a little bit of acid is enough to cause damage, together with that digestive enzyme pepsin, which I mentioned. So I also think that a lot of these things that we're told, and again, I'll reiterate, the coffee, tea, chocolate, soda, greasy food, fried food, fatty food, spicy food, alcohol, soda, alcohol, etc. And everybody right then says, but I have a cup of coffee. Is that okay? Because that's all people care about is their coffee. I don't think these cause reflux. They do trigger it, set it off, make it worse, but they're not the cause. And it's important to make that distinction. And so again, these are all different types of dietary recommendations and behavioral recommendations that have been well studied in the GERD literature, but really not studied at all in the LPR literature. And some of them make sense. High fiber is better. Low fiber is worse for diseases. Now, tomato, acidic fruits, there's a caveat there. These are actually very healthy for you to eat. And as I said, I don't think they cause reflux. But for somebody with a chronic reflux issue, eating an acidic food or beverage is going to cause some inflammation and discomfort. And you can see, again, all these different types of things people eat and drink are contributing factors. So carbonated beverages, even seltzer, is an acid. It's a weak acid, carbonic acid, but acid is acid. So we need to avoid these certainly early on. And I tell my patients, it's hard to hear all this because we're all used to eating and drinking all this, but let's do it for a short period of time. Now, keep in mind, most of my patients have seen 5, 10 other doctors. They're frustrated with their problems. So by the time they see me, I'm usually willing to get them to make some changes that I suggest. And again, some further behavioral changes which have been studied in GERD, but not LPR. So now we're going to switch to meds. And of course, this is the very popular topic in the United States because that's all we do is prescribe drugs. And there are better ways. So we have different categories. There are medicines that protect the surface of the throat and the esophagus. We have medicines that help move things along. There are medicines that lower the tighten the sphincter of the lower esophagus, and then we can suppress acid. So these are medicines that I actually do like to use. These are basically medicines you drink a teaspoon or two with meals before bed, and they do different things, but the goal is they prevent acid from touching the mucosal or the skin lining the throat and those surfaces. And they're really relatively safe. They don't interact much with other drugs or medications. And in my mind, these are really good tools to use. Again, I don't look at these as treatments or cures. A newer product on the market is Reflux Gourmet. This is what I now use as my workhorse. You can buy it from a large country called Amazon, and they'll deliver it to your door. What it does is it coats the throat and the esophagus with something called alginate, and this is made out of seaweed. So it's safe, there is no side effects, minimal risk of any interactions, and it's well tolerated. And again, another healthy tool to use to help minimize acid exposure. Now, the H2 blockers, these are drugs that block release of acid through the histamine receptor, and there's a whole bunch of them. And we all know the names, the cimetidine, famotidine, ranitidine, nitazidine. These are all the different drugs that are out there that help stop acid from being produced. And they're very effective acid blockers. They're not as good as the proton pump inhibitors or efficient, but they still work well. And they are relatively safe. And I'm sure many of you have heard some of the side effects of taking long-term proton pump inhibitors. The same studies looked at the H2 blockers and really didn't see any significant correlation. So again, I use these as a tool. It's interesting because ranitidine was taken off the market because of the risk of cancer from the NMDA content. Well, interestingly enough, if you grill chicken, you get the same nitrosamine created by grilling the meat. So, it's pulled off the market because of these risks, and often things in the media do cause items and whatnot to be pulled off the market. Regardless, there are many other options. And then PPI therapy. And really, these have been used since the 80s. They truly are a miracle drug. They were designed to stop acid secretion in the stomach, and they work extremely well. They're very effective and efficient. And we know that there's a lot of benefit in the GERD literature. Clearly, it stops symptoms. It can help people with chronic ulcerations and inflammation, and maybe for chronic suppression of Barrett's esophagus, which is a precancerous condition. The problem, as I said earlier, is most people take these drugs for decades, no longer for months too long, but for decades too long. And the data for the reflux affecting the throat, LPR, is really unclear. It's about 50-50. So you can flip a coin whether a drug will work or not. And essentially, we don't typically think that there's a lot of support that the medicine helps LPR. Of course, it does in some people, but not in everybody. There are side effects. And the typical ones are headache, diarrhea, abdominal pain, nausea. These tend to get better as you use the medicine and you get used to it. They kind of go away. We know there's some issues with calcium malabsorption, possible risk of hip fractures. We see increased risk of a pneumonia for people taking these. And what we've seen over the last couple of years, the last decade, is there's been numerous studies that have been printed showing that there are other risks. So damage to the kidney, heart, potential dementia, though that's sort of been debunked, maybe stroke risk. there are other factors involved too, and other diseases, and we see these coming up on really quite frequent basis. Now, these are all big data studies. These are basically data mining studies where they take a lot of data, a lot of patients, and they mine it for patterns. So it's not the gold standard double-blind placebo-controlled trials, but the difference is there are many of them, and they're all suggesting that there may be some risk of using a medicine long-term. My point is, why use a medicine in the first place? And we'll get to that. And the same studies that looked at H2 blockers didn't have the same risks for the H2 blockers, which means there may be something to these studies. The most recent ones looked at COVID, and it looks like that if you take these medications, you'll have an increased risk of having COVID or an increased risk of having a worse outcome with COVID, which might make sense. It suppresses the acid, which protects the stomach, and actually is an antibacterial or antiviral part of our health. And if you suppress that, you may mitigate that. So we know that a lot of people get some of these diet and behavioral modifications. This is the area of non-compliance, which is really hard to combat. And frankly, it's the most important in order to prevent this. And, you know, Western philosophy, and I'm sure all of you have experienced this before. You go to the doctor. So you got a problem, they put you on the PPI. Well, you're not better, so, oh no, you need to take it twice a day. Well, that's not working, so let's change to a different brand. Oh, and let's add on an H2 blocker. This is the norm. Most people get this type of treatment. And people don't stop and think, maybe something's wrong, and maybe this isn't the medicine of choice. And I think this is where we can make the greatest advancements at helping people. So I'm going to switch gears now and talk about more or less my transition to plant-based medicine. And I came across this book, The China Study, written by T. Colin Campbell, really brilliant, really wonderful, nice man. And he was an NIH researcher. This is all funded. And essentially the premise of the book is, our chronic diseases, diabetes, heart disease, stroke, cancer, are caused by the Americanized diet, which is mostly our heavy meat-based diet. So the animal protein in our diet causes these diseases. So I'm thinking, if it causes these diseases, I bet it causes reflux also. And that's sort of where I started. And, you know, we're really not a healthy country, as I'm sure most of us know. We are spending billions of dollars a year to treat reflux disease. And most of this is in medications, actually. Our country, despite the billions of dollars, trillions of dollars we spend a year, is really not even ranked in the top 20 of healthcare. I mean, there are countries that spend far less than we do, who fare far better than we do. We use more medicine than any other country in the world, and in many cases of the industrialized nations, 3 to 4 times their amount. So much so that we should be the United States of Pharmerica. Too many people are on medications. 81% are on one prescription drug, and 40% of Americans over age 65 are on 5 or more drugs. And you notice the top 3: antidepressants, statins, and PPIs. Billions are spent a year. Despite all this, our chronic diseases are increasing, and unfortunately, so is the death toll with these. Obesity is out of control. And what's alarming is the pediatric population, it's increasing at a really high rate, upwards of 20% more per year. Is there a coincidence that if you look at the BMI or the body mass index increasing over time, that it overlaps with the profits from the fast food industry? I don't think so. Weight's important. Obesity independently is a risk factor for multiple cancers, and that includes multiple cancers of the mouth and throat. So we need to make some changes. If we don't, we can't afford this. We can't afford to see people dying from these diseases, having significant morbidity from them, and also the financial costs. So what we need to do is look at the evidence. And I'm going to go through some of the studies that have been done, and this is all accessible online. So the Seventh-day Adventist study was a study that looked at hundreds of thousands of Seventh-day Adventists. They don't smoke or drink, do drugs, but they do have a varied diet. And what they found is, in this subpopulation of 30,000 Californians, they found that those that ate red meat had double the risk of cancer. Now, anybody listening to this will be like, yeah, of course, red meat's no good for you. We all know that. Well, what about chicken and fish? And by the way, that's one serving or more a week. So the chicken and fish eaters had triple the risk of colon cancer for the one or more serving a week. Those that ate legumes more than twice a week had half the risk. Looking at the health professional study or the nurses' health study, these are combined studies with, again, over 100,000 people. This follows doctors and nurses for many generations, many decades now. And there's clear evidence that processed and unprocessed meat had an independent risk of dying from cancer and heart disease. We look at the NIH AARP study. This is more than 500,000 people that were looked at, and they find this more or less the same information, that red and processed meat increase the risk of dying from cancer, heart disease, and dying prematurely overall. And white meat, the chicken and fish, was increased risk of cardiovascular mortality. The EPIC study is a similar study that was done in Europe with also nearly 500,000 people, finding the same correlations. The more meat in the diet, the more risks of various cancers and other diseases. In particular, they focused on pancreatic cancer and prostate cancer. But also there were many subcategories of these studies that were looked at, looking at breast cancers and many of the other chronic diseases. Again, all trending towards the more animal protein in the diet, the more likelihood of having a chronic disease. This is the EPIC Panacea study, that when you control for calories, eating meat, particularly poultry, was more closely linked with weight gain than other food sources. The World Health Organization has finally come around to realize that, red meat is probably a carcinogen. So it's now a group 2A carcinogen. Now, how many of you give your children hot dogs or like to have some prosciutto? Well, guess what? They're group 1, class A carcinogens. These cause cancer in humans. They're in the same category as smoking, asbestos, and cigarettes. So just think about that for a second. So what is the Mediterranean diet? Well, we have the American definition, which is, little red meat, lean meat, some eggs, mostly fish, lots of oil, some cheese. This is not where the Mediterranean diet has come from. This is what we Americans have created. The typical American diet comes from the Isles of Greece and Italy, where they ate 90 to 95% plant-based diet. And yes, they did have a little bit of eggs and some very lean protein in a rare while. Fish was not eaten constantly. And yes, they did have olive oil, but not to the degree that we've created this. And so my interpretation of what the Mediterranean diet is, eating a plant-based diet with 3, maybe 4 meals at most a week with a couple ounces of any kind of animal protein, preferably fish. And that's what I tell my patients. And again, the evidence is mounting. These are all journal papers. They come out on a weekly basis showing that the more plant in the diet, the healthier you'll be. The more animal in the diet, the less healthy you'll be. And let's not forget, there is an environmental impact, despite what some people tweet. It is true. It is not a hoax. Animal husbandry is one of the larger causes of greenhouse gases. It causes deforestation, uses up a lot of clean water, and a lot of fuel that goes into making the beef. It's always interesting to, basically you need 25 calories of energy to make 1 calorie of meat versus 13 calories to make 1 calorie of grain. Now, look, if the fast food chains are now going plant-based, they clearly know we're onto something. By the way, it's not that bad. Actually, you can't tell the difference between the original burger. Now, I'm not saying that eating the plant-based meats alternatives are healthy. I'll say that I use them as a bridging way to get people off of real meat, and a couple times a week at first, and then once a week, then to once or twice a month. There's a lot of fat, a lot of salt, and it's processed. So processed foods are really not healthy for us. But again, it's a good transition tool. So let's go back to reflux, and let's talk about diet in terms of reflux disease. So Jamie Kaufman came out with this book, Dropping Acid, and great title, by the way. And her premise was that our foods are acidified, so we're eating and drinking a lot of acidic foods. Eating and drinking acid's a problem. So if we decrease that acid, then we'll decrease the disease. And the premise is that pepsin, that digestive enzyme that comes up to the throat, it's activated by acid. So if we decrease acid, less pepsin. And she did some studies looking at pepsin as one of the major factors causing inflammation. Found out that drinking alkaline water can really help neutralize acid. This was done sort of in a petri dish. And these are all hints that acid's a problem and diet is the issue. And so she started that revolution where let's try diet. And, she did a study with about 20 people showing that there is some benefit to having diet over drugs, and people did improve their symptoms. The problem is acid is an issue. There's no question. But remember, this is a disease of acid and pepsin. So a low acid diet can help, but even a little acid that comes up can still activate pepsin, the digestive enzyme. So I'm thinking, why not target pepsin? Because pepsin is created in the stomach. When we eat meat, it's broken down into amino acid chains, which activate the receptor for pepsin to create more pepsin. So animal protein, which is easily digested in the stomach, creates more pepsin. Plant-based protein is bound to all the fiber, and that's not digested until it's into the intestine. So it bypasses this positive feedback loop. So my thinking is, how can we address the pepsin part of the equation? Well, we do eat far too much protein in this country. I mean, the USRDA for protein is 0.8 grams per kilo. This is about 56 grams a day. In the US, we eat 3, 4, 5 times that, depending on the person. So I'm thinking, let's decrease the animal protein. We'll have less bioavailable amino acids in the stomach, less hormone to release less pepsin and acid. And there's actually data that supports this. And again, I think we should all be listening to Hippocrates. Let food be your medicine and medicine be your food. So we did a study looking at diet. And what we did is compared a group of people that had proton pump inhibitors with the dietary changes like coffee, tea, chocolate, soda, versus a group that was treated with this plant-based Mediterranean diet, the alkaline water, and the same coffee, tea, chocolate, sodas. And what we found was that looking at the aggregate of all the patients, there was no major difference. Well, that's a huge statement. We are getting people just as better, just as healthier as the drugs were. So right there is a huge statement. But if you look at some of the subcategories, we do notice that the diet does better, especially when people are having coughing and swallowing issues. And there are a couple other studies have been done showing that if you feed people a plant-based diet, they in fact have less acid created, less acid exposure time, and there's less gastrin, less pepsin. So the data really supports that, both what we've seen and what others have seen. So my treatment for reflux disease has changed dramatically. I do tell people to avoid the same triggers, the coffee, tea, chocolate, sodas. And again, I think these are triggers, not causes. They need to be stopped or at least cut back sufficiently initially. And I do tell people we'll be able to put these back in within reason. Alkaline water is a great tool. It is a high pH. You can find this in many pharmacies or supermarkets. And I like the ones that are naturally occurring. I don't like it made in a laboratory by adding in some chemicals. And I tell people just drink this until you have clear urine. That means you're sufficiently hydrated. People with liver or renal diseases, kidney diseases, need to check with their doctors because it can change the acid base slightly. Now, Reflux Gourmet, I mentioned earlier. Again, I use this as a really great tool to help minimize acid exposure. Typically, I give this to people who have a habit with meals, like a teaspoon or before bed, or if they wake up at 3 to pee. And then, of course, the important thing is you need to change the diet. I think the data is clear. I've given you sort of a small slice of what data is out there that exists. But fruits, vegetables, grains, and nuts should be 90 to 95% of what you eat. I don't really have any restrictions of what it is, meaning you could eat whatever you want. If something bothers you, then stay away from it until things do get better, because as you stay on this diet, you will get better. If you're overweight, you'll lose the weight. And this is how you're going to get rid of reflux also. And, I just tell people simply a couple times a week, have a couple ounces of whatever meat, preferably fish, and try to keep things whole food, plant-based. It's best to have less than 6 ingredients. And what we've done is we've applied a lot of this research to a lot of other diseases, which are all respiratory, head and neck, throat-related diseases. So some people have chronic shortness of breath. You've heard of COVID people feeling short of breath all the time without any findings of wrong with the lungs. Well, these are sensory symptoms. Reflux can make that worse. So if you decrease reflux through diet, then you can help people with this problem. Same with chronic recurrent coughing. So again, treating reflux with a diet approach. And tonsil stones, they're caused by our diet, and that can be treated and improved upon dramatically with diet changes. And finally, kids primarily with breathing disorders, trouble breathing inward. Most are diagnosed with asthma, and they start doing sports and they have trouble breathing. That's not asthma at all. It's called exercise-induced asthma by the lung doctors, but it is actually a vocal cord disease. Reflux plays a role in that as well. And, it's important that you don't stop your drugs. Now, I mentioned the proton pump inhibitors. There I go again. And, PPIs are really wonderful tools. They should be utilized when they're indicated. You should never stop your medications without consulting with your doctor first. And if you do decide to start tapering off the drugs, you can't do it until you've made substantial diet changes. But what I have my patients do is, as they change their diet, they'll start losing weight. As you start losing weight, you start to taper off the medication slowly. You can take days, weeks, or months, whatever the need is. Now, some people really are, in a sense, addicted to this medicine, and when they stop it, they get a rebound where the acid, it's horrible, the burning, the discomfort. So that's why we have to do this slowly. Now, there are side effects to using a plant-based approach and stopping drugs. Most people lose weight. On average, my patients come back 8 pounds lighter on their visit 6 to 8 weeks. I lose over 300 pounds a week. All reflux symptoms get better. This is both for GERD and LPR in the vast majority of people. Now, it's true, there are people that have problems with their anatomy that predispose to this. And certainly for those that have had symptoms for decades, they're definitely more challenging to change. A lot of change in other diseases. So cancer, heart disease, stroke, diabetes. I touched on the data, but there's a plethora of data supporting that diet prevents and reverses many of these diseases. A lot of my patients, after 6 months, a year, come back saying, "Hey, doc, I don't take this medicine anymore for my diabetes. I'm off medicine for blood pressure." That's because these are diet-based diseases that will improve with a change in the diet. Now, shopping sprees for clothing, insurance doesn't cover those. And again, I have people transition slowly. Start out real slow. Do 1 meal a week, then 2, then 3, then 4, etc. Use the meat alternatives as transitioning tools. To me, the most important thing, and I provide my patients with a lot of information, is you got to read and educate yourself. You can hear me talking about all this, but once you start looking at the data, reading the books that are out there, and then finally, try foods. Again, I'm 98% plant-based. I do not miss the meats. I don't miss anything. And when I have them, to me, I just don't feel it has much flavor. It's the stuff you put on top that has the flavor. Now, of course, you could say that's in my mind, and it probably is, but so what? If it works, it's great. But the point is you will transition your tastes much more differently and more readily than you get used to it. Now, once again, Canada, of course, is far ahead of us, and this is their food pyramid, so to speak. And what we can see here is they clearly know what they're talking about. So you have 3/4 of this plate is fruits, vegetables, grains. 1/4 is the protein quarter, but look carefully. What do they have? A serving is 1/4 of an egg. They've got beans, legumes, soy. They've got 3 slices of chicken. Look at how much that is. That's not even 3 ounces. And 3 tiny cubes of beef. And that's not milk, which is what you see in the American version. I think they may have taken that out. At least I hope they've taken that out. This is water. So clearly, this is a 95% plant-based diet. And that's what Canada uses as their, quote, food pyramid. And truthfully, what I tell my patients, again, many have come to me because they've been to many docs and they're frustrated, but there's nothing to lose by trying something different. And there's a lot to gain. Now, I mentioned education. This is really where I think everybody needs to do their homework, to do some reading, to understand what's going on in the world of diet and nutrition and how it affects chronic disease. I have all my patients, at least I recommend this book. I tell all my residents and people rotating through, visiting professors and whatnot, read the book. Now, this book is written for the masses. It's really easy to read. And what it does is it reviews the majority of the dietary nutritional literature up until when it was published, which I think is now 5 or 6 years ago. And, I don't think it's the Bible end all be all, but it clearly suggests that we have to look at our diets and realize that most of our chronic disease is due to our diet. And there's movies to watch. There's a lot out there that you can rarely get. These are my books. This is my book that I've published. I have the chapter in here on reflux disease. This is the authority on the Mediterranean diet. And again, this is a much more comprehensive look at reflux disease, but my book is the first one that combines LPR, GERD, and a diet-based approach. So you can continue lining up and going to the pharmacy and getting the pills, or you can go to the pharmacy and start on a different road and a different path, which I will argue is a far healthier one. And I thank you for your time and attention.
Fantastic. Thank you, Dr. Zalvin. This is so thorough and just really fascinating. Of course, for those of us who may not have full-fledged diagnosed reflux disease, to be able to go through all of these symptoms and understand that so much is interrelated. And of course, we always love to make the connections between chronic disease in one zone of, showing up as chronic disease in another zone. The body is a holistic system. And I think that was the best piece of learning that I took away from Dr. Campbell when I read his book. So thank you. Really great. And we have some great questions coming in that I'd love to bring to your attention.
Sure.
I'm going to start with the question about Barrett's esophagus. Could you, first of all, explain a little bit about what Barrett's is and tell us if you've been able to see an impact on folks with that condition using a plant-based diet as your first line of defense?
It's a great question. I'll preface it by saying I'm not a gastroenterologist. So typically Barrett's disease is treated under the purview of a gastroenterologist. That being said, I diagnose Barrett's all the time because I do all my own esophagoscopies. I don't treat the Barrett's. I do refer. I have a GI doctor who is a advanced endoscopist and expert, and other GI doctors that I work with. But that being said, Barrett's esophagus is a condition where, because of chronic inflammation, reflux, a portion of the lower esophagus changes the cell type, and it changes into a type of cell that can then turn into cancer down the road. Now, just because you have Barrett's doesn't mean you're going to get cancer. There's still not a high transition rate, but it is prevalent. So if you have no Barrett's, the risk of getting cancer is very low. If you do have Barrett's, that risk goes up depending on how abnormal the cell types are. Now, that being said, it's diagnosed with biopsy and treatment. The standard of treatment currently is the use of pretty much lifelong proton pump inhibitors. Now, that's something that clearly needs to be looked at. I can tell you I have many patients that go on a plant-based diet, their reflux symptoms all go away, and their Barrett's goes away. Sometimes the Barrett's itself doesn't go away, but the severity of the cell damage improves. So we have a system called dysplasia, and dysplasia is abnormal cells. And we've seen that, if you have no dysplasia, the risk of getting cancer in the setting of Barrett's is far lower than if you have high-grade dysplasia. So definitely diet can play a role, but we've not yet done these studies, and they really do need to be done where we take patients and examine them for long periods of time, those that have chosen a medicine route versus those that have chosen a diet route, and of course with chronic surveillance. So currently the recommendation is do what your gastroenterologist says with regards to Barrett's. My goal is prevent it. You don't get Barrett's if you're on a diet that is going to prevent reflux in the first place.
Excellent. Thank you so much. There are a few questions related to how to get off of a PPI. What do you recommend as sort of the steps to take, and how long does it generally take for different people?
So again, I'm going to preface that by saying you need to speak to your doctor first. Don't use this lecture as I want to stop my medication tomorrow. That would be irresponsible. You need to speak to your doctor. You need to come up with a plan to basically transition. Stopping a PPI without making substantial dietary changes will fail. And again, so everybody's different. Now, I do a slow taper with my patients, meaning once they've lost substantial weight, their symptoms are markedly improved or gone, then we start to taper off the medication. So they may take it for 2 days and skip a day and do that for a week or two or a month or two. They may then do every other day, then every third day. And that's sort of a slow taper. In addition, sometimes I use the H2 blockers that I mentioned earlier, those other acid suppressants in between to help bridge that gap. But again, I just want to strongly reiterate that don't do any changes to your regimen without discussing with your doctor. And if your doctor is not open to the idea of diet being good for you, then find another doctor who is.
Thanks, very helpful. I'm curious, so there's a question here related to, let me just go back to it. Here, okay, swollen nodes in the neck. Have you seen swollen nodes in the neck related to LPR specifically?
Oh, no, you do not get any lymph nodes in the neck from reflux. There is a different problem that's there, and that you should see a head and neck surgeon for. ENT who specializes in head and neck.
Okay, great, good to know. Someone asked, which whole plant foods would you recommend for someone who is underweight and has acid reflux? So maybe they don't need to lose weight or want to lose weight.
So it's a great question, and I'm not a nutritionist. So this would be somebody who I would refer to one of our plant-based nutritionists. There are clearly high calorie dense plant-based foods that are out there. Volume tends to be higher that you need to eat. The caloric density is certainly lower with many of these foods. But things like avocados, coconut, etc., have higher calorie. But again, I'm not a nutritionist, and certainly if there are people dealing with weight issues or being underweight, then I would strongly recommend working with a plant-based nutrition person. And again, I'm not saying that you need to be 100% plant-based in order to get the benefits of a mostly plant-based diet.
Great. Can you also speak, the second part of that question, could you speak to the whole food plant-based side of things? So when we talk about whole foods, something like a white rice versus a brown rice, or added sugars and oils, how do those feature into either acid or pepsin or, issues related to reflux disease?
So, very simply, I look at whole food as being, if you read a label and there's more than 6 ingredients, it's probably not a whole food. And, with regards to acid reflux itself, the more processed the food is, it tends to be more acidic. Foods are processed, there's lots of preservatives. Those preservatives tend to be more acid-based preservatives. So acid alone is a problem. And again, the more we process our foods, the more unhealthy the foods are, generally speaking, for our general health. And again, looking for eating the whole food is a far better way for our bodies to absorb nutrients. You see lots of, in the past, people would take vitamin D and they take vitamin E, and we find out that, guess what, maybe this isn't even good for us because we absorb nutrients far better in the whole than we do by the individual components. So that's sort of the definition of whole food. And again, in relation to reflux, it has to do mostly with the acidity of the processed foods. Not all processed foods are acidic, but many can be from some of the ways that they make these compounds.
Great. And I remember earlier in the talk, you gave us such an interesting visual of, when the animal protein comes down into the stomach and it's broken down, there's no fiber to go along with it. And with the plant protein, it's always coming with fiber. And so we have a nice question about the science here. Do you know the mechanism by which animal proteins are activating pepsin compared to the plant-based protein?
So there's not so much a difference between animal and plant as far as the protein. I mean, of course, there's different content, different amino acids, different a quantity of amino acids. Any amino acid combination can activate the cells in the stomach to release something called gastrin, which is the hormone that then goes to the stomach and has other cells release something called pepsinogen. Pepsinogen is the precursor to pepsin. So what happens is, when you have a meal and there's a lot of protein in that meal, you release more gastrin, more pepsinogen, more pepsin. Well, pepsin then breaks down the protein into more amino acids. So you get this circle where you're having more and more amino acids, and more acid in pepsid. The difference is plant-based protein is bound to the fiber much more so than animal-based protein. And therefore, we don't digest much of the plant-based protein in our stomach. A lot of it bypasses and goes into the intestines where much of the digestion occurs. And that bypasses that mechanism, so you're not getting that gastrin surge, or you're not getting that increased acid. And there's been studies that show that, in fact, if you feed a plant-based meal, you have less acid exposure and less pepsin or gastrin. Contrary, more animal-based, the higher acid, the higher pepsin, the higher gastrin.
That's really helpful. Someone else here has been whole food plant-based for a few years now and has had a chronic cough, always attributed to post-nasal drip and allergies. So the question is, is it possible to still have reflux issues even when eating a plant-based diet, a wholesome plant-based diet? And, could it just be allergies? Could it be something else? Or what would you do in a situation like this?
So the answer is, this is my favorite type of patient. And this person has probably seen 6 other doctors. They are on multiple nose sprays. They've been on inhalers. They've been on PPIs. And this is the typical story. And this is alluding to what I mentioned early on in the talk about the nerve-based disorders. So the answer is yes, you could have all those things, but I guarantee you have none of those things, nor is this a reflux disease. Your chronic cough is most likely, again, I don't know you, I've never seen you, but most chronic cough like this is a nerve-based cough disorder that's called an UCC or RCC. So it's an unexplained chronic cough or refractory chronic cough. Together, it's called a neurogenic cough. And what happens is we have hypersensitivity in our throat. So even a little acid can trigger it. A little drip from the nose can trigger it. Talking, laughing, eating, drinking, cold air, all cause a tickle sensation that makes the person cough. And I know the person on the line right now is going, oh yeah, that's me. So this is a nerve cough, and it is not reflux or allergies or sinus disease. I mean, it can be, but you would have been better by now if it were any of those. So this is something that you probably should see a laryngologist, somebody like myself, who can help differentiate and treat this for you.
Great. Fantastic. A question about sort of the breathing and the relationship with burping and acid in the throat. So somebody says, sometimes if I get an odd influx of air, like a recent lung function test, I get a ton of nonstop burps and acid in the throat. Does that also fall into this category of reflux disease, or is that some other?
It's probably not a reflux issue. It's probably more of an esophageal motility issue. And that actually does affect reflux disease. It's a topic I didn't get into, but there are many people that have these nerve issues that affect the nerve called the vagus nerve. Well, the esophagus is controlled by the vagus nerve, as is the lower sphincter in the stomach. So if there's damage to that nerve, which can occur with viruses, then there can be dysfunction of the coordination of the swallow, the movement of material through the esophagus, and the valves, the closure of the valves, all of which can certainly cause and contribute to many of the symptoms, not necessarily just reflux, but many of the symptoms I mentioned earlier.
Great. And can you tell us also, so somebody had a question about the voice box. How is it exactly that GERD and LPR affect the voice box? The second part of the question is, if an older person had one of their vocal cords paralyzed seemingly overnight one day, could it have been due to an ongoing acid issue while sleeping, for example, that wasn't diagnosed?
Sure. So again, 2 different diseases. GERD is gastroesophageal reflux that affects the esophagus. LPR is reflux that comes up into the throat and causes those symptoms. They're different diseases because you don't need to have GERD symptoms if you have LPR. The esophagus is well protected against acid, whereas the throat is not. So they are different diseases. It's part of a spectrum of disease, but they are different. No, you cannot get vocal cord paralyzed by reflux disease. Remember, reflux doesn't cause hoarseness. It can make things worse. Paralysis of the vocal cord is the exact same mechanism that people wake up one day and their face doesn't move, Bell's palsy. Some people wake up and they can't hear. Some people get COVID, they can't smell. These are viruses that affect the nerve, and in this case, the vagus nerve or the recurrent laryngeal nerve, which moves the vocal cord. That is by far a very common presentation of people with acute onset. And it's not just old people, it can be anybody. Typically not children. It's rare that I see this in kids. A few in the 20s, more so in the 30s, and then 40s on up is where you see most people presenting with an acute viral neuritis of the nerve that moves the vocal cord. Not caused by reflux.
Great. And you know what, I'm going to stop sharing here also so we can see a little bit more clearly. But one other question related to diet now. What is the current evidence for the effect of non-fat milk or dairy on both LPR and GERD symptoms? If you could speak to each.
So I don't know that there's any studies looking at the different types of dairy. I just say avoid all types of dairy. It's not healthy for you. It's not going to give you what you need. And I just don't recommend dairy. I think dairy is a high content of animal-based protein and certainly can stimulate the secretion of acid and pepsin, as I've outlined earlier.
Great, thanks. Another question about the hiatal hernias. I don't know if you would cover that as an ENT. Is there evidence that a hiatal hernia is caused by GERD, or is it just sometimes associated with GERD?
How about if they're completely overdiagnosed, number one? And you know, I've rarely seen a report that doesn't say mild esophagitis, gastritis, and small hiatal hernia. So I think they're overdiagnosed, number one. Number two, really large hiatal hernias, which are basically herniation of the stomach into the chest cavity, that can predispose to reflux episodes. But again, for people that still have a competent sphincter system, especially the upper sphincter, it doesn't mean you're going to have reflux into the throat. And that in those cases, when they are severe, there are surgeries that can correct that. But again, the goal is let's not get to that point. Obesity, poor diet is the major cause. We can prevent that in most people. But that is not my area of expertise.
Got it. Thanks. There was a follow-up on the dairy question. You know, how do you feel about the various types of plant milks?
They're delicious. No, I mean, you know,
What's your favorite?
Oat milk is my favorite, but I like soy milk, oat, soy, whatever it is. That's you know, it's your choice. Some of them are higher in sugars. You know, some of them have lower calories. Some are higher calorie. You just have to find what works for you.
Fantastic. Any other questions from the group? You all had fantastic questions. Thank you so much.
And thanks for the questions.
Yeah. Very good. All right. Well, thank you. This was so informative, and I love how we can really start to tease apart not just the different forms of reflux disease, but also so many different issues that, you know, sometimes are perhaps misdiagnosed, or we think of them together and yet they're really disparate things. And I hope that this has given people some new tools to go out into the world and you know, experience the throat differently, experience breathing differently perhaps, and just so much that we can take away from this. So thank you so much, Dr. Zalvin.
The pleasure. Thank you very much for having me, and everybody go out and read. That's the way to learn this, is just study, learn, and you'll make some changes.
Absolutely. And I'm sharing in the chat box here a number of resources for any of you who would like to take a next step. That's what we do here at Plant Powered Metro New York, is we try to help you not just learn the information, but then activate it in your own life as best as possible. So as I mentioned early in the talk, for anybody who came in late, Dr. Zalvin's book may be a wonderful resource for some of you who do want to go deeper on the topic. And the title of that is in the chat box. I also want to welcome many of you who might be new to whole food plant-based nutrition to come into some upcoming virtual spaces that we have that are designed for folks who want to start down the path for the first time. So on Thursday, December 9th, we'll have our monthly session on how to get started with whole food plant-based nutrition. You can sign up at the link in the chat box. We're also excited. We're doing a big, very long and playful celebration for Giving Tuesday called Plantathon just after Thanksgiving. So if you'd like to join us, there's information about that in the chat box as well. Many different speakers from all over the country and a lot of local folks too, all bringing in different angles about plant-based nutrition, both personal and scientific and lifestyle-based. And then something really wonderful coming up in person. This is one of our first larger in-person events in a very long while, but we'll be hosting, along with the Marlene Meyerson JCC Manhattan, Dr. Neil Barnard, who is a wonderful speaker about all things related to plant-based nutrition. He's going to be talking about cognitive health specifically in his talk, Power Foods for the Brain, which will be on Monday evening, December 6th at 7 o'clock. And I put a coupon code in there for anybody who'd like to sign up to get $5 off the price. And one last question for you, Dr. Zalvin. Are you seeing patients now, and can folks reach out to you and if they're interested to have a consultation?
My office, Sleepy Hollow, New York. I saw a question about telehealth. We don't do telehealth. It's all in person. And yeah, just you go on ENT Analogy, the website. I think my email's there and my link to my website. And you can even schedule your own appointments on entanalogy.com.
Fantastic. Thank you again so much. And I wish you all a wonderful evening and a very happy holiday next week. Take care.
Everybody enjoy.
Thank you.
Thank you.